An exciting day planned for you. We hoped you all had enough to eat for breakfast this morning, and we're gonna be ready to get started. So I'm just gonna go over introducing how the day is gonna be like, and then Michael is gonna do a quick update about what aHUS Canada has done over the last year. So welcome to everybody. Just wanted to introduce you to our board members that we have. Michael, my husband, Michael Eigenram is the vice chair. He's over there. Sonia, don't know where Sonia is. She must have stepped out. Yeah. Sonia is our treasurer. Marguerite, that's myself. And then Carrie Stogren, she's sitting at the table there. She's from Alberta. Glenn is her husband. He was not able to be here today. And then we have Nancy Lafleur. She's sitting at the table there. And Brian Chepkema is also another board member who was not able to be with us today, and he's also from BC. We have a group of medical advisors that we talk to sometimes on a regular basis, sometimes on a lesser basis, but Dr. Licht is our pediatric nephrologist that we have as a medical advisor, and most of you probably met him last night. He was at our dinner with his wife. And then we have Dr. Anne-Laure Lapeyrac from Montreal. And then we have Dr. William Clark from London. Christopher Chan. Patrickon was our speaker last year. For whoever was here last year, you might remember him as our key speaker. And then Michelle Main, she is our clinical consultant, and she works with Dr. Licht. aHUS Canada, what do we do? aHUS Canada is a not-for-profit organization that was formed in November of 2012. Our mission is to support patients, families living with atypical aHUS. And all aHUS Canada board members are either caregivers to aHUS patients or are patients themselves. Today we have Dr. Licht going to be speaking. As I said, many of you already met him last night. And then Dr. Hadlunowicz is a local clinician from Toronto who will be speaking about certain things, how to live with aHUS. John Bylok, who is sitting at that table over there. Many of you might have already spoken to him. He did a survey a while back, and he is here to give us an overview of the results of that survey. Then we have Lisa DeLolo, who's sitting in the back of the room there. She is our GR person. We hired her last fall, and she has been instrumental in getting us meetings with the government. And then Ryan Clark, advocacy consultant. He's also sitting beside Lisa at the back table there. He helps us and consults, gives us advice on how to do certain things with advocacy. And then we have Keegan Johnson, who's not here yet, but he will be our key speaker for the afternoon. He will be speaking to us how we can go from here, how we can get more involved with our organization. He has a son that has a rare disease and has extensive experience in the rare disease world, and he will be giving a presentation in the afternoon. And then in the end of the day, we'll just have a time of sharing with patients just your stories on what you have experienced living with atypical aHUS. Some of you have already volunteered to share your story. If there is other people that are willing to be part of that and are willing to participate, then during the day you can come up to me and you can let me know if that's something that you would be interested in. Michael will now give an update on what we've been doing since last year. Also just wanted to let the speakers know, whoever is speaking, just make sure before you start speaking that you get a little mic and talk to our videographer so that we can get the voices on our video in the proper way. Enjoy the day.
We've been able to get another newsletter out, the aHUS Avi Shua. We've engaged and supported patient caregivers. We've met with several families as a board of directors and consultants to help them with their strategizing of their advocacy efforts. And we were able to secure public funding for Solaris for an aHUS patient here in Ontario. Since that time, we also were able to secure interim funding of Solaris from the Ontario government as well. You might notice from my presentation we've done a lot of work in Ontario, and if you're from another province, don't feel left out. We just feel that because we are living here and because Ontario is leading the way in some regards with all of Canada, that if we make progress with Ontario, that will carry forward to other provinces as well. So just because it seems Ontario-centric does not mean that your province is left out. We think that the efforts we're putting in here is going to translate to the other provinces also. Recently, a couple of weeks ago, Dr. Tim Goodship from the United Kingdom had an opportunity to come to Toronto for speaking at the U of T. And so we got wind of that. He let us know and asked if he could help us in any way with our patient community. So we, of course, jumped on that opportunity because he is such a world-renowned expert. So we met with the Ontario Ministry of Health and with patients with him on the day that he was available. And that has turned out to be very beneficial for many reasons. I think we can translate that information to Canada. We kind of look up to the UK model of use of Solaris as an ideal. So I think his input's going to have some effect here in Canada in the short term and the long term. Some of the government highlights. We've met with senior policy advisors in Ontario's government. We've met several times with the Ontario Executive Officer. Her name is Suzanne McGurn. She's basically the person in the Ontario government who makes the final decisions on which drugs get funded and which ones don't. So she has a very powerful position. She has a team of people that she works with, and she's been very accessible to us. We like her attitude, much better than the previous executive officer that we met with. So we feel like we're able to make progress with her. Some of her team members are a little bit more difficult to work with, but at least she, as a final decision maker, has been good to work with. So we feel positive about that. Early this year, I believe in January, I had a chance to make a presentation to Ontario's finance minister on behalf of our association, so that he heard directly from us about the need that we have, because we felt it was important to not just meet with the Ministry of Health, but other ministries as well, so that all ministries are aware of us and they get a broad view of our needs. Further meetings with the Ministry of Health has told us that the funds are available for this drug. So if anybody tells you that the government says there's no funds available, it's not true, because the ministry says it's available. As long as the Ministry of Health says it's necessary, the funds are there. We also held a lobby day in February at the Ontario Legislature, where we had a press conference preceding that day, and then we met with a lot of MPPs at the government offices that day. That was a very fruitful day, and just happened to be that right after our press conference, the Minister of Health made an announcement that they were going to have this interim funding of Solaris for select patients that meet the criteria. So this criteria we found was quite restrictive, so one of our big jobs is going to be to loosen up that criteria. Some advocacy highlights. We've been using this email tool, which I think a lot of you are aware of, on our website. To date, we've registered 3,300 letters sent to the ministers and ministers of health. So we think that's been effective. And we've had a petition campaign in Ontario this past fall, and we were able to deliver over 8,000 petitions in total to the Ontario government. This drop-off here that Marguerite and I made with Eric Hoskins, our health minister, was just under 7,000. That represented the bulk of them, but we also had the opportunity to deliver from separate patients to their own MPPs. Media highlights. As you know, we've had some segments that were running this past year, newspaper, radio, and TV segments. Very high profile in well-read newspapers like the Toronto Star and the Toronto Sun. So I hope you've seen some of them, and if you haven't, some of that information is on our website as well. Some of the goals for the year coming up. We're going to encourage the other provinces to provide interim funding. Like Ontario is right now, we don't think it's acceptable that the other provinces just sit and wait to see what Ontario does further. We're going to engage patients and other associations from other provinces if they're interested in helping us. We are going to continue writing and sending letters to the provincial drug plan managers just to influence them and try to put some pressure on them to make changes in a positive direction. We want to connect more with patients, caregivers, and physicians to provide support. So we're going to try to keep reaching out to more patients, find out more about who they are, because that can be difficult at times. They don't always want to get involved. But we'll only do that on a comfort level that they have. We want to add additional patient stories to the aHUS Canada website. Currently we have 3, and I'll admit my story's not even on there, so we have work to do to improve that. We need to recruit new board members to the association for our succession plan. Marguerite and I have been on for a couple of years already, Sonia as well. We need to have new board members joining. We need to begin fundraising in order to gain more independence. Currently we receive a lot of funding from Alexion, and we want to become more independent, so that'll be one of our goals for this year as well. And we want to continue to distribute e-newsletters to the patient community so that they're more up to date on our activities. It's kind of a time-consuming process, and that's probably why we haven't been able to do much of that recently, but we want to do that more. As far as government goals go, we want to engage the governments in all the provinces of Canada. Right now, as I said, we're really engaged in Ontario, but we want to become Canada-wide. So we're going to ask the provinces to do what Ontario's done so far, instead of waiting until they have a final plan. We're going to reach out to the drug plan managers and health ministers from those provinces, the opposition health critics and premiers. Anybody who's listening or who gives us any response, we'll make some conversation with them to keep a dialogue going. Our advocacy goals, we're going to engage additional families and physicians, as I mentioned earlier. We need more advocates around the country. We want to secure additional meetings with members of provincial parliament, MLAs, MPPs, MNAs. These are the people that we want as representatives of patients. So patients that live in Nova Scotia or Alberta, Manitoba, we want them to meet with their local representatives. And those are the people that can put some pressure on the government for them, because they're representing them after all. Supporting advocates to meet with their local MPPs and MLAs. Conduct advocacy activities such as letter writing, petitions, etc. So if we get into a province where we feel that it's worthwhile to start another petition in that province, that's what we'll do, and get people in that province writing letters as well, using our email tool. For media goals, we want to support additional patients and caregivers to advocate through the media. So when we have an opportunity that we think is going to be useful to have further media exposure, we will help support them to be comfortable with that procedure. Sustaining disease awareness and pressure on governments through the media by securing additional stories, just to get more awareness in the community of the rare disease, since it's so unknown. Even by doctors, we find they don't know much about the disease, if they know it at all. And our goal is to help communicate the value of the drug for rare diseases and impact of access and lack of access for patients. That's the end of the slideshow. So the next speaker is John Bylok. Some of you have had contact with him by phone already. He's been instrumental in putting together patient information from our community in Canada, and he's glad to be here to present the results of those interviews that he made with us. So, John?
Good morning, everyone. Thanks so much for the opportunity to come in and present the first phase of the patient input program. I really appreciate the invite from Michael, Marguerite, and Sonia. And also like to thank everyone who participated in the first phase. It was incredibly illuminating, and it's the first phase in a journey as well with regard to the input program. And I'd like to present some of the key findings right now of what we talked about last fall. So essentially what we've done is set up a patient input program to collectively measure people's experiences with regard to this disease, how it impacts on the patient, the caregiver, and the family. What we want to do is find out your experiences, the impressions you have with regard to the disease, and do that on an ongoing basis, because the importance really is not doing a one-time snapshot of your journey, but it's measuring your journey over time so that we can establish benchmarks to measure how effective your lobbying and your advocacy is going forward in getting access to the medications available, getting diagnosis done quicker, getting your genetic testing done quicker, because everything in this journey revolves around waiting. And what we want to do is eliminate as much of that waiting as we can. We want to understand what the changes are as you go forward. You know, how are your emotions going? You know, I know this is an emotional roller coaster. Profile your experiences, and most importantly, look at what's happening in the future, because obviously in the future, hopefully there's going to be more opportunities to access medications, etc. And obviously the feedback that you give us with regard to your experiences, how you'd like to receive information, how regular you like to receive information. Obviously new information on a clinical basis is important to find out as quickly as possible. So what we did really was talk to a group of patients and caregivers across Canada. We used the aHUS membership list as a way of reaching out to you to participate in the program. That worked really well, and we also used social media. We conducted WebEx interviews over the telephone, which we did those in the fall of last year. They averaged about 50 to 70 minutes in total. They were very in-depth. We were able to get a really good understanding of the journeys that everyone had with this disease. And what I really was amazed with was with the participation. We had a total of 22 respondents in total take part, 12 patients and 10 caregivers. And also, my background, I've been in this healthcare for almost 30 years. As my daughter, who's turning 18 in a week, tells me, boy, you're getting old. One of the things I've noticed over my career is the importance really of the collective voice in patient diseases, particularly in a disease like this, where it's so rare. And the fact that you guys have come along so far in such a short time, I applaud the board in putting this group together, and I applaud you all for attending these groups, because as you know, your voice is much stronger collectively than it is individually. And we also did interviews in English and French, and participants received an honoraria for their time. As Michael alluded to, right now, a lot of the members are from Ontario, but we also had a voice from across Canada, BC, Manitoba, Quebec as well. We had a good range of patients We had caregivers who I really appreciate the time you gave to speak about the experiences your children and you have had with aHUS so far. And also, most of the patients were female, and most of the caregivers were female, which is generally the case when I've done research in other areas. Women, thank God, are willing more to participate in things like this and share their experiences than men are. I don't know if it's a gender bias in some way or not, but I'm kind of atypical from a male perspective. My wife can't get me to shut up, so. Okay, what we're going to do now for the next 10 or 15 minutes is show you the highlights of the research. As I mentioned before, the importance of this program really is in establishing benchmarks. Benchmarks with regard to how long your journeys are in total, how long it was before you were properly diagnosed, how long it took to get testing. I mean, everything in your journey relates to time. And what we want to do is to limit that time, as I mentioned before. By establishing benchmarks, we'll be able to measure how effective going forward the program is. Are you being diagnosed quicker? Are you seeing fewer doctors? Are you getting access quicker? So most patients' caregivers suspected another disorder prior to their diagnosis. Most common symptoms exhibited were they're feeling tired, they couldn't understand what's happening to them. So as you can see, most of the patients and caregivers had another disorder. Or a small percentage suspected there was nothing wrong with them at all, but some of them suspect, obviously they did not suspect you had aHUS at the start. What condition did your doctor suspect you had prior to being diagnosed with aHUS? In a majority of the cases, it was TPP, or TTP, sorry. So as you can see, again, what we want to do is reduce that percentage from close to 70% to lower so that people recognize the fact that perhaps it's not TTP, or maybe they should consider something like aHUS earlier. How would you describe your level of concern when you realized you have aHUS? Okay, basically, obviously, the reactions to this disease are very strong. Your concern is extremely high. So again, you're reacting to something that you never heard of before. You're getting frustrated because your introduction to this disease the whole process is frustrating in that the doctors really don't know at the outset or what you have. How familiar would you say you are with your treatment? One of the things I noticed right away when I was talking to you all was the fact that, again, because there's so little information available, that everyone goes to the internet right away to start looking for information, to start getting a better understanding of where you are or what this disease is. So research is very high. A lot of you spend a lot of time in front of your computers looking for information, hoping that there's new information available. Is there any new clinical data that's coming along? Being passive in a disease like this is certainly not an option. Getting involved is the most important thing that everyone can do. So as you can see, the familiarity, everyone is familiar with this disease. You don't have an option not to be familiar. What do you do in order to get information? Obviously, you're educating yourselves. One of the things, I got a few friends that are GPs, and then the things they tell me all the time is they're so busy. There's a shortage of them in a lot of areas. They can't possibly know everything about everything. And a lot of times, the people in their waiting rooms have more information about the disease they may have or suspect they have than the doctors do themselves, particularly because there's so many diseases out there that are rare or ultra rare. This is one of the benchmarks that we really want to change. What was the length of time between when your doctor first suspected you had a health problem to when you were diagnosed with aHUS? On average, you fed back 35 months, which is almost 3 years. You know, when you look at 35 months, I mean, just that on itself is very frustrating. But that's one of the benchmarks we want to change going forward. There's some people that was even more than 3 years. So, you know, there's some people that are getting diagnosed within a month, a few months, but then there's also people that are taking a long time. So what we really want to do when we show this graph in a year or so is have everyone here so that you're getting into this process as soon as possible, because you can't really get results until you're properly diagnosed. Which resources do you find most useful? Outside of the medical community, outside of doctors, nurses, etc., the two most reliable and accessible resources are online searches in the aHUS patient board. So again, this shows, just kind of verifies what I mentioned before, that everyone's going to the internet, and as everybody knows who's gone to the internet, some sources are reliable, and some aren't. It takes a long time to figure out where you should go for information and how accurate that information is. Thankfully, the aHUS board has done a very good job in providing a very valuable resource to the patient community overall. And the fact that a lot of people are relying on it for information speaks well to the organization itself. Because also this is potentially a disease that can impact various family members, people who've gone through this journey understand it obviously better than others who haven't. So the family is an important part in the resource as well. How many doctors on average do people see before they're diagnosed? 14 on average. So think about it. Over the course, on an average of just under 3 years, you've seen 14 doctors before you've been diagnosed with aHUS. That, you know, every doctor you see potentially diagnoses you properly or not. But the issue really is the fact that it's 14. If we can reduce that again, not only is your journey faster, but the impact on healthcare costs is lower. What we intend to do through this research is just give you guys more ammunition to use in terms of when you do advocate the fact that obviously getting access to this medication or whatever medication's available in the future decreases cost. Nephrologists make the most diagnoses. As you can see, this is a rundown of the 22 patients involved in terms of the number of doctors seen. So there's a lot of people who are seeing a lot of doctors. And there's a lot of people out there who may not necessarily even know they have aHUS yet, who haven't even started their journey like you have in terms of getting to the point where they can actually identify what they have so they can get properly treated. Plasma infusion does not treat the underlying cause of aHUS. Well, most people are aware of that fact. And I guess the frustrating thing for a lot of you is that you are aware of that, and you are aware that there's a solution available, but you haven't gotten access to it yet. Who initiated the conversation about a prescription medication? Doctors generally initiate the conversation about a prescription medication, but that should change hopefully as more people become aware of what's available out there. The conversation about this new medication details the fact that there is a drug that offers a real opportunity for transplant and a drug that can change the course of the disease by repairing, restoring kidney function. Now, these are two topics that what we'd like to see get increases over time. Because as doctors become more familiar with the fact that it can impact these particular types of patients as well, the greater the likelihood is that the access is going to become more available, we hope. But it is a new drug on the market. It's the only drug on the market that treats the disease, not just the symptoms. And obviously, quality of life is important. That's one thing that's permeating healthcare, even chronic diseases. People are differentiating their products, even in Me Too categories, about quality of life. Okay, all these products work the same, but this particular product impacts my quality of life better. Everybody wants to get to a point which they recognize is where they were before that disease was introduced. So the reaction to eculizumab is very positive. It offers a better quality of life, a chance to get back to normal. For people who are waiting for transplants, it normalizes your body. And that's an important fact, that a lot of doctors are not willing to do a transplant until you get access to Soliris. The frustrating thing is you can't have your transplant until you get access to Soliris. And so far, short-term data shows that the product's working very well. Obviously, as we go forward, there's going to be more long-term data available. However, there is a solution at the end of the tunnel, but people are getting frustrated because they can't get access. Hopefully that changes, and more of the 17 people that we talked about might go get access to that drug now. But it's still in early stages. So why do people like the treatment medication that's available? Well, the quality of life is better, it's working well, it normalizes your body, it's the only medication that treats the disease. People are very happy or grateful, it's easier to take. That's another thing. Obviously, when you kind of compare dialysis, plasma therapy, I mean, they're very invasive. Being able to take a medication like Soliris certainly improves your quality of life just because of that. So right now, of the 22 families or patients that we talk to, 50% are on medication. And again, people like the fact that Soliris has given them the opportunity to get back to normal. They appreciate the fact that their quality of life has improved. Obviously, it reduces the stress involved in life. They feel great. So the difference in a lot of people's lives and the words they use to describe their journey changed significantly once they were able to get access to this treatment. OneSource, most of the people we talked to were aware of OneSource. And the feedback we received about OneSource was it was great, was helping get access to nurses and infusion. So the overall program itself was very appreciated. The most important thing in this research is finding out what you think, what should be done, what suggestions you have. And the fact that you can help yourselves by feeding back what kind of suggestions are important. This is a very vocal group. You're a lot further ahead than other ultra-rare disease disorders who haven't even organized themselves yet. So again, kudos to the board in organizing this great patient group and in yourselves for attending these events, because as I mentioned before, your strength is in numbers. So Obviously, one of the frustrating points in this journey is that everyone expects their doctors to know everything about everything, but as I mentioned before, that's impossible. Universal access. The term universal healthcare in Canada in some ways is a misnomer because people expect universal to mean that you have access to every medication available, and obviously that's not the case. Stop diagnosing. Obviously, if you get diagnosed sooner, then your journey through this process is faster. Quicker access to funding. Don't take as long to grant funding. More awareness of the disease total. Obviously, as more people are aware of aHUS, more people are able to participate. Treat faster. Circulate new information. One of the important things for a group like this is getting access to new information as fast as possible because everyone's looking for new information. Are there new drugs coming along, etc.? Circulate new information regularly. Ensure all patient cases are available online. Maybe having a forum where specialists can access patient cases in aHUS as easily as possible will help them better understand their patients. Less frequent treatment, obviously, if it doesn't have to be as regular as it is, and a lower price, obviously, as well. So I'm going to summarize, kind of take you through the journey step by step. So in pre-diagnosis, as I mentioned before, it's an emotional roller coaster. Feelings of disbelief, anger, confusion, and denial. aHUS patients and their families start their patient journey not necessarily knowing what they actually have and why they have becomes ill so fast after being healthy. So you're going from a period where your health is really good to one where things start to go wrong and you're wondering why. Why me? The initial visit, in essence, the starting point of your journey, or the official starting point, is fraught with confusion, denial, surprise, and of course, serious concern. Many of these patients, caregivers, families are shifted away quickly from a normal, healthy point to one where questions may not be answered, or even, in many cases, take very long or too long to be answered. So again, the frustration is not only in the fact that you have a disease that you never heard about before, is that you really can't get answers as quickly as you want. Diagnosis. Patients feel that it takes forever to be correctly diagnosed with aHUS. The average time between the doctor first suspected and when you were diagnosed, again, is just over 1,000 days. I think if you take 35 months and turn it into days, it resonates even stronger. Most patients are initially diagnosed with TTP, and the average number of doctors seen is 14 before a correct diagnosis is made. So again, these are two key benchmarks that we want to change going forward. We want to lower the number of patients who are diagnosed with TTP first, and we want to lower the number of doctors seen. Patients and caregivers, in fact, all family members and even friends are all impacted initially. So this is a disease that's frustrating for you to explain to your family and friends because their first reaction is, well, what is it? And there's also levels of being scared or frustrated, confused. It's an awful, terrible disease. Many of these patients also highlight the fact that a lack of information or knowledge adds to their frustration. So as I mentioned, not only do you have to deal with the fact that you have a disease you never heard of, but you can't really get access to information when you want it, as quickly as you want to. The most common treatment pathway right now is plasmapheresis, dialysis, kidney transplant, and then prescription medication. So again, going forward, obviously we want to introduce prescription medication earlier into the treatment pathway. particularly when the diagnosis is clear, so that there's no need to start off with something else. Get access to the treatment that we know is available as quickly as we can. Everyone knows that the options out there aren't really treating the disease. So in situations, as I mentioned, where diagnosis is clear, don't waste the time. And again, it all goes back to time. If we can cut time down, if we can cut those 1,062 days down, if we can cut all the different nodes in this pathway eat up time, our goal really, as a community, is to reduce the time within each of those nodes. The introduction of the prescription medication changes people's perspectives. People get back to feeling they have somewhat of a normal life. They can get back to feeling like they're working, that they can go be more active, to do things that they were doing before they got sick. Emotionally, that brings people to such a nice, kind of happy place, which is where they deserve to be. And then changes in outlook are all related to the time you've had this disease, the time you've put into it, the time you've spent, the late mornings you spend on your computer looking for information, formulating plans for yourself or collectively as a group. The fact that there is a treatment available, that there is a light at the end of the tunnel. Some people have been fortunate enough to get access, and some haven't. So the frustration in your lives and not being able to get access to that medication. So there is a happy ending. There is a finish line. But crossing that finish line is still a challenge. So basically this kind of summarizes where we are right now with regard to just giving you a quick overview of the market research. As again, what we want to do in the first phase is establish some key benchmarks going forward, and we hope to start the second phase of interviews next month, is to build on this, to get more people who didn't participate in the first phase involved, because as I mentioned, the more people we have collectively, the more powerfully this resonates, and the more powerfully you can use it as ammunition in terms of your advocacy. Because there's a lot of information here that shows how better access, quicker access, diagnoses that are done properly, quickly, impact time, impact that waiting time. And what we want to do, as I mentioned before, is reduce the waiting time as much as possible. So, any questions? Yep.
Are you going to make this accessible online?
Yeah. Yeah, this actually, I'll give Sonia, Michael, and Marguerite a copy of this. But also, yeah, you can put it on your website, I guess. But again, it's something useful to use, for any of your individual. But again, it's just a good story. If anybody asks you, what is aHUS? Just show them this presentation and show them, what you're going through, what the challenges are, what you need to do going forward. Yes.
Do you have any sense of how many people you might get in the second wave of the survey?
Well, the importance obviously is getting all 22 who participated in the first wave to go forward, because we're comparing data, we're measuring their journey going forward. But I hope, and I understand we've had 4 new patients in Ontario, is that correct? No, I mean on Solaris. Yeah. So I'm hoping that everyone who didn't participate in this program participates in the next phase. There's a lot of people who, because, human nature being the way it is, there's a lot of people who haven't gotten to the point where they feel comfortable going to groups like this to share their experiences. They feel like, they want to deal with aHUS within their own little bubble right now. And, even getting access to those people who don't meet with you collectively, but I can still we can still get their voice to resonate and help us with regard to this research. So again, we want to reach out to everyone as possible to answer your question. So I hope everyone who didn't participate in this program sees the value of giving us their voice so we could add to this collective ammunition. Any other questions? Well, thanks so much. I can't say how much I appreciate the involvement everyone has given, the time they've given to get for this research program. The input program, as I mentioned, is an ongoing opportunity to measure the impact and the experiences, the challenges, the hope, and hopefully the success going forward in your treatment. Thank you.